Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 155 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, JDL, a 47-year-old female patient presents to the accident and emergency department with a chief complaint of sudden onset 4-day history of cough, fatigue and fevers and chills. She resides at their family home with her spouse and is generally healthy. She has an active lifestyle and jogs 25 miles per week. She hasn't traveled recently and works from home. Her pertinent vitals include a respiratory rate of 32 breaths per minute, a blood pressure of 124 systolic and 71 diastolic, a heart rate of 98 beats per minute, an SaO2 of 93% on room air. Her WBC is 19 × 10⁻³ cells per millimeter cubed, and her body temperature is 38.9 degrees Celsius. She has a BUN of 17 mg per deciliter. She is alert and oriented, and this has been established on 3 occasions. Her chest X-ray shows a left lower lobe consolidation. Her pertinent labs include a Legionella urine antigen is negative. Mycoplasma pneumoniae and Chlamydia pneumoniae are also negative from respiratory polymerase chain reaction (PCR) results. She is admitted to your general medical ward for the treatment of pneumonia. So my question to you is, which of the following is JDL's computed CURB65 score? Is it A, 4, or B, 3, or C, 2, or is it D, 1? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D1. The CURB65 score can be used to assess a patient's risk of mortality related to pneumonia and to make hospital admission decisions. 1 point is assigned for each of the 5 criteria the patient meets. They are then summed for the final CURB65 score. The patient is not confused, so she earns 0 point for that, and BUN is no greater than 19 mg per deciliter, so she earns 0 point for that. The patient's respiratory rate is greater than 30 breaths per minute, so she earns 1 point for that. She has a blood pressure greater than 90/60 mm of mercury Hg, so she earns 0 point for that, and she is younger than 65, so she earns 0 point for that. Therefore, her CURB65 score is 1. That makes answer D correct. Answers A, B, and C are incorrect. Please progress to the next question. And the next question reads, which of the microbes listed below is the most likely cause of JDL's pneumonia? Is it A, Mycoplasma, or B, Haemophilus influenza, or C, Streptococcus pneumoniae, or is it D, Staphylococcus aureus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Streptococcus pneumoniae. Answer D is incorrect because Staphylococcus aureus is not a common cause of community-acquired pneumonia. Further, the patient's symptoms and chest radiography are not as severe as with Staphylococcus aureus pneumonia, and she has no history of MRSA infection or recurrent skin infections, which may be risk factors. Answer B is incorrect because the patient is admitted in June, and in the Northern Hemisphere, influenza is only in season primarily in the winter months. Answer A is incorrect because the patient did not have an indolent onset of pneumonia as is common with atypical bacteremia. Answer C is correct given the aforementioned, and Streptococcus pneumoniae is among the most common bacterial causes of community-acquired pneumonia. Please transit to the next slide. And the next question reads, the attending physician is considering ceftriaxone monotherapy for JDL. Basing on JDL's history of presenting illness and the results from the CAPSTART study and the study from Garin N. al., published in JAMA Internal Medicine in 2014, which of the options listed below would be the best therapeutic recommendation for JDL? Would it be A. vancomycin plus ceftriaxone, or B. azithromycin plus ceftriaxone, or C. levofloxacin monotherapy, or would it be D. ceftriaxone monotherapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. ceftriaxone monotherapy. Answer C is incorrect. The patient is an avid runner, and fluoroquinolones should be avoided, if possible, because of their risk of tendon rupture in athletes and patients of advanced age. Answer B is incorrect, given the patient's acute onset of disease and lack of positive atypical results. Atypical pathogens are unlikely. Furthermore, the post-MDF 2015 RCT showed that beta-lactam monotherapy was non-inferior to beta-lactam plus macrolide therapy for non-severe pneumonia in the case of non-ICU community-acquired pneumonia. Answer A is incorrect because the patient does not require therapy for MRSA, given the low risk of this being an etiology, and there is no need for two agents with Streptococcus pneumoniae activity because the patient is being treated on a general medical floor for non-severe CAP. Therefore, answer D is correct. Please proceed to the next question. And the next question reads, on day 5 of hospitalization, JDL has improved. His pertinent vitals include a respiratory rate of 18 breaths per minute, a BP of 112 systolic and 70 diastolic, a heart rate of 70 beats per minute, an SaO2 of 98% on room air, her last fever was 73 hours ago, a WBC 12 times 10 power 3 cells per millimeter cubed. JDL is due for discharge today. So my question to you is, which of the strategies listed below would be the most appropriate for JDL now? Would it be A. continue antibiotic therapy for 2 more days with levofloxacin orally at discharge, or B. continue antibiotic therapy for 2 more days with amoxicillin orally at discharge, or C. continue antibiotic therapy for 2 more days with azithromycin orally at discharge, or would it be D. discontinue antibiotic therapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Discontinue antibiotic therapy. This patient has been afebrile for more than 48 to 72 hours, is saturating well on room air, is normotensive, and has a normal heart rate and respiratory rate. She has no signs of clinical instability. Given this, it is safe to discontinue antibiotic therapy now, making answer D correct. According to the IDSA guidelines as well as the findings from the Aranga al. 2016 RCT, answers A to C are incorrect because she does not require additional therapy, given her clinical stability. If she did require additional therapy, levofloxacin would be suboptimal, given the risk of tendon rupture and other adverse effects, and azithromycin would be suboptimal as well, given the high risk of Streptococcus pneumoniae resistance and lack of concern for atypical pathogens in this case. Please transit to the next question. And the next question reads, PCN, a 63-year-old female patient presents to your accident and emergency department in early February with a chief concern of fevers, muscle aches, and shortness of breath for the past 36 hours. Her pertinent vitals include a respiratory rate of 34 breaths per minute, a BP of 113 systolic and 70 diastolic, a heart rate of 109 beats per minute, an SaO2 of 90% on room air, a body temperature of 38.4 degrees Celsius, her WBC is 16.1 times 10 power 3 cells per millimeter cubed, a procalcitonin concentration obtained in the accident and emergency department is 0.05 mcg per liter. Despite suffering from dementia, her mental status has declined from baseline, according to the nursing home. Her chest X-ray shows bilateral consolidations. There are no records of her receiving any pneumococcal or influenza vaccinations. She is admitted to the general medical ward for the treatment of pneumonia. So my question to you is, which of the microbes listed below is the most likely cause of PCN's pneumonia? Is it A. Mycoplasma, or B. Influenza, or C. Streptococcus pneumoniae, or is it D. Pseudomonas aeruginosa? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Influenza. PCN presents in early February with symptoms of influenza, namely fevers, and body aches. That makes answer A incorrect. Atypical pathogens are unlikely because she has an acute infection and did not present with an insidious onset of disease. Answers D and C are both incorrect because her symptoms are most consistent with influenza, making answer B correct, and her procalcitonin is less than 0.25 mcg per liter, suggesting a viral etiology. Please advance to the next slide. And the next question reads, which, if any, of the therapeutic options listed below would be the most appropriate to initiate in PCN's clinical scenario? Would it be A. Vancomycin plus piperacillin, tazobactam, or B. Azithromycin plus oseltamivir, or C. Oseltamivir, or would it be D. Supportive care only? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Oseltamivir. Answer A is incorrect because the patient presented within 48 hours of symptoms from likely influenza and therefore should receive oseltamivir, making answer C correct. Answer B is incorrect because this presentation is not consistent with atypical disease. Furthermore, the procalcitonin concentration is normal, suggesting that a bacterial infection is unlikely, making answer A incorrect because her syndrome is not consistent with bacterial disease and she is not severely ill. If she required antibiotic therapy, e.g., procalcitonin greater than 0.25 mcg per liter and or more severely ill, coverage for MRSA and Pseudomonas would not be indicated, given her lack of risk factors for those. Please transit to the next question. And the next question reads, which of the vaccines listed below would you recommend for PCN to receive after discharge? Would it be A. PCV13 followed by 23-valent pneumococcal polysaccharide vaccine, abbreviated as PPSV23 1 year later, or B. PPSV23 followed by 13-valent pneumococcal conjugate vaccine, PCV13 1 year later, or C. PPSV23, or would it be D. live attenuated influenza vaccine, abbreviated as LAIV, and 23-valent pneumococcal polysaccharide vaccine, PPSV23? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. PCV13 followed by PPSV23 1 year later. The Advisory Committee for Immunization Practices does not recommend LAIV, given its questionable effectiveness, making answer D incorrect. The patient may have additional benefit from inactivated influenza vaccine. Although PPSV23 used to be the only recommended pneumococcal vaccination in otherwise healthy adults older than 65, PCV13 is also indicated now, making answer B incorrect. Answer A is correct because both vaccines are indicated, given that the patient is older than 65, with the PCV13 given before PPSV23, if possible, making answer B incorrect. Please proceed to the next question. And the next question reads, RCT, a 45-year-old male patient sustained a 40% total body surface area burn to his left side with likely inhalational injury requiring mechanical ventilation. RCT has been in the burn ICU for 1 week. Overnight, RCT had a body temperature of 38.9 degrees Celsius, an increased WBC of 18 times 10 power 3 cells per millimeter cubed, and an increase in macroscopically purulent sputum production. RCT is now hemodynamically stable with no signs of new-onset organ dysfunction. His chest X-ray is difficult to assess, given his inhalational injury. The respiratory therapist was asked by the fellow to do a bronchoalveolar lavage, BAL, for suspected ventilator-associated pneumonia, VAP. The culture was sent to the microbiology laboratory. So my question to you is, which of the following would be the next best course of action in RCT's case? Would it be A. Send blood and urine cultures, and await their results before initiating empiric antibiotic therapy, or B. Await preliminary quantitative culture results before initiating empiric antibiotic therapy, or C. Use gram stain results to determine empiric antibiotic regimen, or would it be D. Initiate broad-spectrum empiric antibiotic therapy for suspected multidrug-resistant MDR VAP? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Initiate broad-spectrum empiric antibiotic therapy for suspected multidrug-resistant MDR-VAP. The patient's condition suggests MDR-VAP, as evidenced by the presence of clinical signs of infection, the patient's increased sputum production, and the patient's having been in the ICU for 5 days or longer. Empiric antibiotic therapy should be initiated after obtaining a respiratory culture and be based on patient-specific risk factors for MDROs, together with local pathogen prevalence and antibiotic susceptibility, to increase the likelihood of providing timely appropriate antibiotic therapy, which makes answer D correct. Waiting for preliminary or final respiratory culture results, as well as blood or urine cultures, could cause an unacceptable delay in appropriate antibiotic therapy. That makes answers A to C incorrect. Please proceed to the next question. And the next question reads, WCP, a 65-year-old female is readmitted to your medical intensive care unit with respiratory failure requiring intubation secondary to severe chronic obstructive pulmonary disease, COPD. She has a past medical history significant for chronic obstructive pulmonary disease, type 2 diabetes mellitus, and coronary artery disease. WCP had a 10-day hospitalization 12 days ago, during which time she received IV azithromycin for a COPD exacerbation. On day 4 of this readmission, a worsening infiltrate is noted in the left lower lung base with increased sputum production from admission. Her maximum body temperature is 38.8 degrees Celsius, and she has worsening oxygenation, despite previous improvement in initial COPD exacerbation. WCP is thought to have VAP, and a semi-quantitative tracheal aspirate is sent to identify the causative pathogen or pathogens. The local medical intensive care unit prevalence of MRSA among all Staphylococcus aureus is 32%, and the most active beta-lactam antibiotic against Pseudomonas aeruginosa on the antibiogram has 80% activity. So my question to you is, which of the empiric antibiotic regimens listed below would be the most appropriate for WCP now? Would it be A. Tobramycin plus linezolid, or B. azithromycin plus ceftriaxone, or C. cefepime plus tobramycin plus vancomycin, or would it be D. moxifloxacin plus azithromycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. cefepime plus tobramycin plus vancomycin. A history of recent intravenous antibiotic therapy is a risk factor for MDROs. Empiric antibiotic therapy for VAP in patients with MDRO risk factors should include agents active against Pseudomonas aeruginosa and MRSA. Empiric combination therapy against Pseudomonas aeruginosa is recommended to increase the likelihood of appropriate antibiotic therapy. That makes answer C correct, and answers D and B incorrect. With a beta-lactam antibiotic as one of the preferred agents, answer A is incorrect. Atypical bacteria coverage is not necessary because their prevalence is low, though it should be considered if the patient's response to initial therapy is poor. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 156.